Right, so this is the cardiopatho lecture, important part. When we look at this, basically the way to view this picture is this is a machine. We are a machine, and taking the breath in brings in oxygen into the lungs and turns the wheel of the machine. As that turns the wheel of the machine, that turns the ability or the wheel of the heart, which then leads to the muscle getting the oxygen that it needs to, specifically your favorite, the mitochondria. And then from there we get CO2 that's leaving through the muscle, specifically through the blood, as we learned in the last lecture, through the heart, and then expired out in VCO2. If we have a condition in which the lung pump itself is affected, anything that might affect respiratory rate, the tidal volume, or the expired ventilation is going to affect the ability of this gear to turn. In the middle here, our heart pump, the cardiac output is the amount of blood that we're going to push through, the heart rate, and the stroke volume, the volume of the blood. All these affect the cardiac output, and so any of these, such as hypovolemia or hypervolemia, would affect the heart pump. And then any condition that would affect if we didn't have enough mitochondria or the mitochondria didn't work, that's going to affect our aerobic metabolism specifically. So this is a big picture of wise, and this is our system. The signs and symptoms of cardiovascular disease, and the cardinal symptoms are chest, neck, or arm pain. And when we primarily look at the types of pain that someone would complain of, it winds up following the same sort of formation for males as an ulnar problem. So T1 pathway is T1 nerve innervation is the area for males, but oftentimes for females, it's much different insofar as where they have their pain. So the female has classically not been done, has not been looked at insofar as studies are concerned or research is concerned on what their signs and symptoms are. Now that's coming to the forefront, and we're seeing a lot more research, and for them, they might have more facial pain and or between the scapulas pain compared to males. The cardinal symptoms, however, for male and or female are these, and palpitations are also included, difficulty breathing, fainting, fatigue, cough, and cyanosis. Others include, because I want you to think of the heart as the pump, and then the blood vessels are part of the cardiovascular system. If the vessels are affected, the heart is affected. If the heart is affected, the blood vessels are affected. And we said this in the blood vessel lecture. So edema and claudication might be common symptoms that occur with cardiovascular pathoconditions. CP is referred to as chest pain, and chest pain may arise specifically from ischemia, myocardial infarction, pericarditis, endocarditis, mitral valve prolapse, or MVP, as you'll see it written, not most valuable player, right? Or aortic dissection without an aneurysm. You may also see these sort of things. And again, I've just mentioned this one insofar as chest pain. Continue then, palpitations are regular, faster, and extra heartbeat that may occur. So when we're talking about an extra heartbeat, we normally think of the heart as sounding as lub-dub, and anything that sounds outside of that, like lub-dub, bub-bub, that is an extra heartbeat and an abnormal sound. We often refer to these with numbers, so lub being S1, dub being S2, and any other sound would be then classified as S3 or S4 if it continued on in that same sort of pattern. Palpitations may be caused by mitral valve prolapse, as you know, rock star and caffeine, anxiety, exercise. The athlete's heart, remember, has that left ventricular wall that's may be enlarged, or severe conditions such as coronary artery disease is what CAD is, cardiomyopathy, complete heart block, ventricular aneurysm, atrial ventricular valve disease or mitral or aortic stenosis. Mitral valve stenosis is different from mitral valve prolapse. Dyspnea may be another thing, and this is shortness of breath, and that's caused by pulmonary patho, which we'll talk about in the respiratory. You may also see trauma, fever, and certain medications might cause dyspnea to occur also. Dyspnea on exertion is doe, a deer, a female deer. No, that's dyspnea on exertion. Okay, and doe may be due to the impaired left ventricle. We wind up with the condition of orthopnea, which is the inability to breathe when lying down. And when we see that, it's often referred to specifically by how many pillows it takes for that person to breathe. So, two-pillow orthopnea would be a situation where someone needs two pillows to get to a position where when they lie supine, that they can breathe. And then paroxysmal nocturnal dyspnea means sudden or intermittent, sudden intermittent periods during the night they can't breathe. Syncope is another one, which is a cardiac origin can cause syncope. Also, obviously, psychological issues could cause syncope to occur. But true cardiac would be conditions of dysrhythmia. So dysrhythmia would be the abnormal contraction of the heart due to abnormal electrical activity. Orthostatic hypotension would be a low blood pressure. We see this a lot in our individuals that are immobile. VBI, you probably have heard about that already in your ortho class. That's vertebral-basilar insufficiency, which is a problem in which the vertebral artery is affected. Aortic dissection is when we have the aorta not working well, and specifically a slice in it. Coronary artery disease and hypoglycemia. The predictors that cause syncope would be, or the increased likelihood of syncope would be a low body mass index. Alcoholism might be another contributing factor. Diabetes mellitus or increased glucose levels. The non-cardiac contributors to someone passing out, again, I've said stress or anxiety, and then migraine headaches, seizures, and some psychological conditions. There's a condition known as vasovagal syncope, in which we know that the heart is supplied by the parasympathetic nerve, and in vasovagal syncope, there's a parasympathetic increase that causes vasodilation that occurs throughout the body. Usually vasovagal syncope is brought on by prolonged sitting or standing, and vagal response I want you to think of as the individual passes out, and then they regain consciousness after they lie down. So they come back to, so to speak. This actually happened to me. I had a vasovagal syncope episode last time that I was in San Diego for CSM, and it's its own unique story. It didn't involve some of the things that you'd think it might. Cough. So a cough is another one. It's maybe pulmonary or cardiovascular issues such as mitral valve prolapse with exercise, stress, or due to a position. So once you get in a certain position, like for me, if I lie down right now, I would start coughing. Cyanosis is that blue discoloration that we see and often visible, maybe due to hematologic or central nervous system problems also. Okay, and then I want you to look up this one specifically, peripheral edema. When we look at peripheral edema, it's the hallmark of what type of ventricular failure. So please look this one up for me. Okay. I think you may have part of the answer in this lecture. Usually it's bilateral and dependent, and it may be accompanied by this condition, which is jugular venous distension, and it's seen in figure 12-13, shows a picture of the jugular vein in a person's neck protruding out, and this winds up being synonymous with the condition that you'll see up here. Okay, and then cyanosis occurs, abdominal distension from ascites. In other words, again, remember that picture of the large belly, the belly was full of fluid. That's looking at ascites. And then claudication. Claudication would be peripheral vascular disease along with coronary artery disease. Again, what do we do with these patients? We try to get them vascular condition versus a spinal stenosis condition. I think it would be best explained by demonstration, but one thing that we do is we put them on a bicycle, and it's known as, in layman's terms, the bicycle test, but in our terms, it's known as the Van Gilderen bicycle test. And so if we have them, if someone has claudication or lower extremity pain when they move and do activity, we do the Van Gilderen or bicycle test. What is that? Well, we put them on a bicycle and we have them bike for a little bit until they bring on their pain. And so then at that point, we have them stop and their pain goes away, right? We test them again by having them bicycle on the bike, but we have them lean forward. If spinal flexion, trunk flexion, relieves the calf pain, then the pain that they're experiencing when they're biking is a positional thing, and it's usually due to spinal stenosis. However, if we put them on a bike and have them flex forward during Van Gilderen's or the bicycle test, and they continue to have pain, then that's true a vascular origin of their pain, and we need to stop it. So remembering this picture and understanding that you need to know this slide insofar as if I'm a red blood cell that's residing in the right atrium or the left atrium, and you should be able to detail the pathway all the way back to its origin place with this. This should be undergrad stuff, basically. Review of the heart. We know the heart has multiple layers, and so what I want to do is, looking at this picture, shows a view from Netter. But when we go through the next couple of slides, you're going to see we're going to talk about these specific layers, mostly because we're going to talk about pathology related to those specific layers. So this picture is showing the pericardium, as you can see in the picture. And then with the pericardium removed, what does that look like? Okay. So looking at this specifically, then, if we were to take the different layers of the heart, if this is the inside of the heart, then we have the endocardium in the innermost part here, and then that muscular layer is the myocardium, and then the layer on the outer part of the muscular layer is the epicardium. Now, the epicardium is kind of synonymous with this visceral layer of the serous pericardium. Okay, so the importance of this then is we have these layers where we have the myocardium, and then we have the epicardium, so upon the heart muscle itself, right? And then we have a visceral and a parietal layer in which, very much like the lungs that we'll talk about, these guys here, there's fluid in between them, so it keeps these layers surface tension pretty good, so that as they move side to side over each other, there is less friction. Now, if someone, for example, we'll talk about a condition in which the pericarditis, for example, is affected, then we wind up with this layer being affected, and conditions such as cocaine abuse will affect this. Okay. And cardiomyopathy is a common condition which we affect this layer too. So again, looking at the picture, showing you the heart, and then blowing up this part right here, right? Now we have the endocardium, the myocardium, and the epicardium. Okay. So this arrow here is the epicardium. Okay. So again, another visual to show you the same idea, what I've already said, but now with some space for you to appreciate that we have this pericardial cavity in between that the epicardium here and the pericardium. So here's the fibrous layer of the pericardium. Here's the parietal layer, the innermost darker green area, and then this is the area where there's a slight amount of fluid in between there and the epicardium, okay, which would be this line right here, okay, epicardium. Okay, busy slide. You probably covered a lot of this in undergrad, but understand that there is in the blue here showing you an SA node, and that occurs up above in the atrium. And then in between the atrium, up here, the two chambers and the ventricles, we have the AV node. The significance of this is that the SA node is where the electrical activity first occurs, and then it's dispersed in this thing known as a functional syncytium, which then allows each one of these cells in the atrium to the electrical activity to go across each of the cardiac muscle cells. As it does that, that fires the AV node, which then spreads down, as you know, the bundle of His and the Purkinje fibers located throughout the ventricles, and causes that then to occur. So this is talking about where the electrical activity is of the heart. If we wind up in a situation where usually happens in older individuals over 65, the SA node specifically does not work. And so this is a condition in which if the SA node stops working or does not work well, then someone winds up with a pacemaker. And the reason why that is these cells as they get older, they don't work as well, and the SA node then stops working. If it stops working, the AV node has to take over. And what winds up happening is the AV node is set at a higher rate, pulse rate, than the SA node. So in other words, if the individual's heart rate goes up and is irregular, as we take their pulse and or do an EKG, then it could be that the SA node is becoming dysfunctional. And if the SA node is, if the SA node is becoming dysfunctional, then the AV node takes over and the heart rate goes up. Now, saying all that, what we're talking about in this slide is, if you can see over here, we have the EKG pattern. And so each area of the heart is shown of what the electrical activity looks like. And it's done in time. So this is occurring over time. And so when we put all of the electrical activity, all the parts together, we wind up with an EKG. And so we wind up with the P, the QRS, and the T wave. And here's it is showing you in time. So as you probably learned in undergrad, then the P wave is representing the atrial portion of the heart. And specifically, it depolarizes during the P wave. Then the QRS is indicative more so of what's occurring down below in the ventricles. And so the QRS complex is right here, and that's looking again at the ventricles. Now, buried within the QRS is, within the atrium, we have a repolarization that occurs, and that is buried inside the QRS. So we don't recognize that. We don't see that in the QRS. Then the T wave, we can see, is ventricular repolarization. So QRS is ventricular depolarization, and the T wave is ventricular repolarization. Oftentimes we'll wind up with this U, but we're not going to spend any time on talking about that. Now the important part of this is if we look at taking this strip and drawing a straight line across, right, then we wind up with what's known as the isoelectric line. And so the importance of the isoelectric line is that we can identify from between ventricular polarization and ventricular repolarization, known as the ST segment, the area between the S and the T. Then we look at that line and we see, is that line at the isoelectric line? In other words, is it level? Or is it below the isoelectric line or above the isoelectric line? And you'll see why that's important in a little bit here. Okay? It's oftentimes used for a clinical marker. All right, busy slide, lots of info, should know all of those components. All right, now this is specifically showing in this slide the perfusion pressure when we are talking about the pulmonary capillaries and the pulmonary veins and the systemic capillaries and systemic veins. So this is on the right-hand side here, a picture of the body, right, and the systemic arteries and systemic veins. And then this picture is showing specifically what's going on from the heart, the right ventricle, left ventricle, right atrium, left atrium, what the pressure is in the lungs. And so all I want you to appreciate here, and nice to know information, right, is that oftentimes the blood pressure in the lungs would be a 25/8, whereas a blood pressure in the systemic system, we know a normal would be 120/80. Okay, and then the mean is looking at the pulse pressure, the difference between them. Okay, if we look specifically in the right ventricle, we know that the systolic is 25 and the diastolic is 0. So it's just appreciating that. Okay. All right, we're moving into pediatric area here, and we will have to start from the base up, and that's congenital heart disease that may occur in the newborn. Specifically, we'll talk about these. So ventricular septal defect is the most common defect. It's the hole that occurs between the left and right ventricles. And so I'm showing you a blue and red arrow because we have deoxygenated blood that resides in the right side of the heart. And if we have a hole in the septum, then the deoxygenated blood may go over into the left ventricle where we would have oxygenated blood normally, and that becomes a problem. So what winds up happening is we take our first breath in after coming out of the womb, then this hole usually closes. Okay, and we're going to talk about another one here in a little bit. Okay, so most kids, this hole is known as the foramen ovale will close, but in ventral septal defect, it continues, so it's open. So the right side of the heart winds up becoming thicker if that is not fixed. The pressure changes and the blood shifts from the right side to the left side. These patients, if they continue without any surgery, then they will have chest pain with exertion with activity. Atrial septal defect, there's a hole between the left and the right atrium. And so again, normally when we take our first breath, now notice the last slide is different from this slide. The fossa ovale closes. So right here, foramen ovale, fossa ovale. If it does not, then the blood from the pulmonary vein enters the left atrium, and some blood then crosses the atrial septal defect into the right atrium, and then, because of that, into the right ventricle. Patent ductus arteriosus is, so in utero, the aorta and the pulmonary artery are connected, and then again, with that first breath, this area closes. If this does not close, then some of the blood from the aorta crosses this ductus arteriosus and flows into the pulmonary artery. And so this is the area that we're talking about. And so this is the area where we wind up with a problem. Patent meaning open, right? Patent meaning open. Tetralogy means 4, right? And it's the number one cause of blue babies. And so we get all of these things that are going to occur. So I'm trying to show in my weirdness here, right ventricular hypertrophy due to the pulmonary artery hardening, because pulmonic stenosis with the pulmonary artery becomes hardened. So this results from the pulmonic stenosis. And this defect specifically leads to deoxygenated blood being pumped into the systemic circulation, and that's not good. Usually requires surgery. Pulmonic stenosis, then, again, I'm trying to show a hardened area of the pulmonary artery, and that leads to the shunt that we just spoke about not working properly. Coarctation of the aorta. In this defect, the aorta actually is narrowed, or there's no shunt that is present, which could condition occurs, it depends on where the narrowing actually does occur. This may lead to severe obstruction of the blood flow in the descending thoracic aorta. And then transposition of the great vessels, the systemic venous blood returns to the right atrium and then goes to the right ventricle and on to the aorta instead of going to the lung via the pulmonary artery. This infant needs surgery immediately. Okay, that's our pediatric conditions. Ischemic heart disease or coronary artery disease. Etiology, this is specifically related to the blood vessel lecture. Atherosclerosis of the coronary arteries, 1.5 million with a heart attack, MI, and 400,000, this condition is fatal. So what signs and symptoms or manifestations we see from coronary artery disease is number one, chest pain, and that's angina. Angina, however, is reversible. Okay, myocardial infarction, as we've talked about before, winds up occurring, and that's death of the tissue. We learned that as coagulative necrosis, and obviously, in lethal situations, sudden death. Angina pectoris is just another word of saying specifically myocardial ischemia is occurring. So the heart muscle or heart, in effect, is not getting the blood flow. And because it's not getting the blood flow, it's not getting the oxygen. Okay. So coronary artery disease specifically, I want you to think of a balance scale. And on one side, you have the demand of the heart or the body specifically, and you have the supply of oxygen. And so coronary artery disease is the demand is greater than the supply of oxygen that's available. So if we're exercising a patient that has coronary artery disease, then we are going to see that that individual might have chest pain. If they have chest pain or angina, then we need to act. And specifically what we do is we stop the activity. If the chest pain specifically is known, then oftentimes the individual, the patient, will do something about that, such as take a medication. But as we are exercising an individual, if they have chest pain, we stop their activity. Okay. Severe ischemia or coronary artery disease is a condition known as Prince-Natal syndrome, and that occurs when the coronary arteries actually close up, and that's thought to be due to vasospasm. And as we said previously, related to claudication, there's severe pain that occurs with ischemia, and so this is ischemia that's occurring though in the coronary arteries that's completely closes up. And specifically, why the coronary arteries? Because the cholesterol accumulates at the area of the turbulence, and there's a lot of turns that occur in the coronary arteries. Signs and symptoms of angina: a gripping, vice-like feeling of pain or pressure behind the breastbone. The pain may radiate to the neck, the jaw, the back, the shoulder, or the arms. This is related to what I talked about previously about males versus females, right? So for females, it can occur interscapular and in the jaw and neck more so than the males down the arm in the T1 distribution. They might wind up with a toothache, burning indigestion, dyspnea, nausea, and belching. And here's that part that we talked about previously, related to the isoelectric line, and that is from the QRS, we have the S, and then afterwards we have the T. And when we see that ST segment depressed, what that means is myocardial ischemia. That means angina pectoris is occurring. So if someone were to have an EKG with chest pain, we would expect to see ST segment depression below the isoelectric line, and that would indicate ischemia. If we saw elevation, that would indicate that someone has had necrosis, specifically myocardial infarction. Okay, the treatment for angina, if someone continues to have chest pain, is dietary, so that you need to be seeing a nutritionist and exercise. So exercise, a routine exercise, will decrease coronary artery disease by 25%. Medication, the classic medication is nitroglycerin. It's known as NTG. Angioplasty, when we think of angioplasty, oftentimes we think that may buy them days or maybe years, but if we don't do number 1, 2, and 3, and that's dietary and exercise, and then be on some type of medication, then the angioplasty does no good. CABG is a CABG, so a coronary artery bypass graft, in which they take a vessel and use that vessel to transplant and create a new pathway for the blood to flow to the heart so that the myocardial ischemia, specifically the angina pectoris, does not occur. So coronary artery bypass graft is what we're talking about, or CABG. In MI, in the majority of the cases of myocardial infarction, sudden formation of a thrombus on a narrowed coronary artery that blocks the blood flow getting the tissue. Myocardial infarction is not relieved by NTG, nitroglycerin, and 30% of individuals that have had a heart attack do not know that they've had one. Signs and symptoms, and the most important one that we see here is ST segment elevation. So that's the difference. ST segment elevation is a heart attack, and ST segment depression, myocardial infarction. Okay? So you need to know that for sure. So severe chest pain, pain radiating down the arms, feeling of indigestion, angina lasting for 30 minutes or more, is unrelieved by rest, nausea, pallor. The pain in the infarct is unrelieved by positional change. So whatever position they get in, they don't feel better. They're diaphoretic, so excessive sweating, shortness of breath, weak, feeling of faintness or syncope. The ST segment that we've mentioned, they may also have a T wave that's inverted or upside down, and their Q waves are abnormal. The types of myocardial infarction, so a subendocardial or a semi, is what it's known as. It's the most vulnerable area of the heart because it's the last place to get blood. So the endocardial layer, again, so here's your endocardium. It's the last then to get blood because it's the deepest. A transmural is a wall-to-wall, so all the way through the wall infarction. So for example, the outside of the heart, the epicardium to the inside, or endocardium. That's a transmural. Diagnosis of myocardial infarction is done by EKG, which I've said. They also do serum enzymes, so a blood test. And so specifically, the body will produce these enzymes when there's damage done. So we know that there is different types of CPK, and CPK-MB is the type that we see in a myocardial infarction. Okay, I'll talk about this more as we get back to face-to-face. The history, so were they doing an activity and using their upper extremities? Using your upper extremities increases systolic blood pressure much more. And when it does that, it's more likely to result in myocardial infarction. And then, obviously, an angiography would be the best way to tell that there's actual blockage. Complications of dysrhythmias, they could go into cardiogenic shock, and in that knocks out 40% of the ventricular muscle fiber. There might be a rupture that occurs, so the transmural MI may lead to a rupture through the ventricular wall. That may result in cardiac tamponade, in which the heart just stops really moving, and or a papillary muscle rupture. An aneurysm, we've mentioned in the vessel lecture, blood vessel lecture. A mural thrombosis would be an inflammatory response, pulling the platelets in the area that forms a thrombus in the ventricle. The problem with that is that thrombus then can become moving or embolism, right, and go up to the brain. And pericarditis, which we'll talk about in a little bit, is an inflammation of the pericardium, and that may lead again to the heart not working, not moving, cardiac tamponade, which limits the venous return. Okay, congestive heart failure. So we're going to talk about two types, the left side and the right side heart failure. And the way I want you to think about this is that really, when we look at it, the left side may create right side. We might have right side and left side, as we'll get to that. But the way that I want you to think about this is the idea of old underwear. So old underwear tend to fit very not fit as well, so to speak, on the heart. And because of that, then the person, as their heart contracts, it doesn't get a full contraction because the elasticity of the heart is all stretched out, very much like old underwear might be. So that's my example. So 2 to 3 million are affected. It's more common in males to have congestive heart failure, and all of these things might contribute to congestive heart failure being caused. Now here's left-sided heart failure, and that is remembering the condition earlier that we talked about, um, how it's related to left-sided or right-sided heart failure. I think correlate these two things will correlate well as we go over this. So the causes of left-sided heart failure is that the MI may cause the backup of fluid into the lungs. The signs and symptoms would be fatigue and dyspnea after mild exercise, that the person has a spasmodic cough when they lie down, they have intermittent difficulty of breathing at night, they have that orthopnea, that they can't breathe when they lie down flat, they have tachycardia, muscle weakness, edema, and weight gain, that should say, not pain, irritability and restlessness, decreased renal function, or frequent urination at night. And the classic sign of left-sided heart failure, is this abnormal heart sound. And so again, just to illustrate, lub-dub is a normal, but then if the next sound that we hear afterwards, lub-dub, lub-dub boom, or whatever, it would be known as the S3 heart sound. So as we're listening to the heart, we hear that abnormal lub-dub boom, or lub-dub boom, some kind of strange sound that occurs that's not normal. That's S3. That's the classic sign of left-sided. Right-sided, and this is the one that we were talking about previously. The cause of right-sided heart failure is left-sided heart failure. So one begets the other. The signs and symptoms of right heart failure would be increased fatigue. They have swelling in their lower extremities, the dependent edema, and specifically, we're talking about 5 to 10 pounds of weight gain due to that fluid. They may also have edema that goes the sacral area, the back of thighs. They may have the S3 heart sound, but it is not. It's more along the lines of the right side leading to the left. The left side, specifically, you will hear the S3 heart sound. And it is known for its S3 heart sound for left. Hypertension, if not treated right, again, that left ventricle wall gets, the mass gets thicker, but doesn't become as strong as the athlete's heart. Not as effective in creating a good contraction. Vascular supply does not improve for those individuals, and it makes them more prone to myocardial infarction or ischemia. And we've talked about hypertension previously in the blood vessel disease lecture. Cor pulmonale is another condition we'll talk about very specifically in the respiratory lecture. It's a lung pathology. It leads to pulmonary hypertension. Going back to the slide that I said it's nice to know, showing you the different pressures in the lungs, then that would cause those pressures to be abnormal. And that is what we see with cor pulmonale. Cor pulmonale, if left untreated, then leads to right-sided heart failure. Other examples then that we're going to spend a little bit of time here on is bronchitis and emphysema, and both of those conditions may lead to cor pulmonale also. Okay, so bronchitis. In bronchitis, there's hypoventilation that's due to the mucus in the bronchi. So there's some kind of irritant then that causes the bronchi to become inflamed. And so in bronchitis, there's not much air going in or out of the lungs. So you wind up with this reflex vasoconstriction, and that increases the resistance to blood flow, which then increases right-sided heart pressure. Okay. Emphysema, so bronchitis is showing an example of linking together the respiratory lecture and the cardio lecture here, in that bronchitis, specifically in lungs, winds up causing right-sided increased right-sided heart pressure, which will lead then to cor pulmonale. Emphysema would be the loss of the lung tissue itself, or parenchyma, and this loss will lead to loss of the lung capillaries. And that loss of the lung capillaries increases resistance to blood flow, increasing the right-sided blood pressure. At the end stage of emphysema, then they go into cor pulmonale. Okay. Rheumatic heart disease is a condition in which group A streptococci will activate the antibodies in the T cells, which you're now very familiar with, and they cross-react with the markers on the cardiac cells in the heart valves. And so the heart valves, the glycoproteins of the valves are affected, and this causes an inflammatory reaction in the heart valves. So we wind up with this group A strep that leads to destruction of the heart valves. And they don't work right, and they cause a bunch of different signs, specifically these, rheumatic fever, wind up with all of these different conditions. So subcutaneous nodules on the extensor surface of the joints, as opposed to rheumatic heart disease. So rheumatic fever causing these things, and rheumatic heart disease causing these things. So non-anginal chest pain, palpitations, fatigue, and difficulty breathing. Endocarditis is the inflammation process of the endothelial lining of the heart and the heart valves. So it fits in with the rheumatic, right? The infective agent is usually the cause, and so some kind of infectious process that occurs. IV drug abusers are one of the conditions that causes an infection in the endocardial layer. And signs and symptoms: fever, night sweats, petechiae, which we talked about, and splinter hemorrhages in the nail beds. So they wind up with a spider-like display in the nail beds of their fingers. Recurrent flus, headache, muscle pains, joint pains, and back pain. Again, confusing because the heart is affected here, but here we have a condition where it's affecting the heart and the joints. Murmurs or abnormal heart sounds, and again, we talked previously about a bruit, B-R-U-I-T, is a turbulent area that's heard through the blood vessel. And so a bruit would be an example then of a murmur. So they're defined as a systolic murmur, or a diastolic, or a continuous. So these are abnormal heart sounds. So we're talking about, as we are listening, we might hear a lub, swish, dub, and the swish would be the murmur itself, not an S3. S3 occurs after S1 and S2 in its normal order. Okay. So systolic conditions would be aortic stenosis or hardening, or the atrioventricular valve not working correctly, which will cause regurgitation or blood going from the ventricle up into the atrium because the valve's not shutting well. And diastolic would be the aortic valve is incompetent, an example. Continuous would be there's stenosis occurring in one place and there's incompetence occurring in another place, such as the condition we talked about, the congenital defect of patent ductus arteriosus, okay, that aorta pulmonary artery connection. Cardiac valvular disease, signs and symptoms is they easily get fatigued, they have difficulty breathing, palpitations, chest pain, pitting edema, orthopnea, again numbered, named by how many pills it takes, or paroxysmal dyspnea, so intermittent amount bursts of not being able to breathe, dizziness and syncope. Myocarditis would be an inflammation of the myocardium. Again, we have an infectious process that will cause the myocardium to be affected. If it's severe, those individuals with myocarditis need a heart transplant while they're on medications. Pericarditis is an inflammation of the pericardium, and that leads to all of these things. And so I want to point out a couple of these that are important. So here's the left supraclavicular area that they wind up with some pain. And so someone with shoulder pain might actually have pericarditis. And so that's one of the things that as you're doing your history, you need to key in on, and that's specifically related to differential diagnosis of what things might be causing the pain. And so when we think shoulder, we tend to think shoulder pain, it's a shoulder origin. individuals also, interestingly, it's relieved the pericarditis by leaning forward, so flexing forward at the trunk, or by sitting upright. So that's another indicator that we can help to differentiate between the different types or conditions. It's aggravated by movements associated with deep breathing, so laughing, coughing, and deep inspiration, which we could see some of these things occurring with the lung disease too, right? Like that. And then aggravated by trunk movement, so side bending or rotation caused a history of fever, chills, weakness, or heart disease. The other key thing with someone that has pericarditis is if they've had a recent heart attack, then they're more likely to have pericarditis. So if they've had a recent myocardial infarction, take note and do these things add up as they are coming in to see us as primary care providers. Cardiac tamponade, we've mentioned before. If we have inflammation around the heart, this is going to limit the venous return. The heart doesn't move as well and doesn't contract as well, and that's cardiac tamponade. Signs and symptoms, there's a narrowing of the pulse pressure, and that's what we talked about when we were referring to the systolic over the diastolic. So between the systolic being 120 over 80, the narrowing of the pulse pressure would be that the two numbers come closer together, such as, for example, 115 over 90 or 98. And this is squeezing the blood vessels, then will raise the total peripheral resistance. Okay, that's why. Cardiomyopathies, these have heart muscle cells are damaged by unknown causes. So again, we said this previously about cocaine abuse would cause it. So different types, congestive would be that we have a dilation process going on. It's usually caused by a viral infection, and the end result is congestive dilated cardiomyopathy. Hypertrophic would be that there's a really thick myocardium, and so that chamber in the ventricle becomes smaller and smaller, and that limits the venous return. And then restrictive, it'd be an unknown cause that the prognosis is going to vary with the amount of restriction that's actually occurring. Okay? So this ends the lecture related to the previous picture from the last lecture. This is the view from the Y, so to speak. So I'm giving you the view from up above looking down at Provo. All right. Thank you very much.